In this case, we're performing a robotic-assisted left renal vein transposition for a patient with symptomatic nutcracker syndrome. We will walk you through the mobilization of the left renal vein, division near its origin, and reimplantation onto the vena cava at a more caudal position, relieving the compression and restoring normal venous outflow. We start by using a varus needle to gain intra-abdominal access in the left upper quadrant. Once pneumoperitoneum is established, 4 8mm robotic trocars are placed in a transverse fashion across the lower abdomen. A 12mm laparoscopic trocar is then placed as an assist port, triangulating the third and fourth robotic ports. This allows for minimal collision with the bedside assistant during the case. The patient is then placed in the Trendelenburg position and the robot is docked. We start by retracting the small bowel cephalad in order to expose the retroperitoneum overlying the great vessels. Once the retroperitoneum over the great vessels is exposed, we develop a peritoneal flap here. This flap will be tacked to the anterior abdominal wall later in the case. This maneuver helps maintain retraction of the bowel and preserves our exposure of the great vessels without relying on a fourth arm or assistant retraction throughout the case. Note the use of monopolar scissors for this dissection. They combine sharp dissection with cautery, which helps keep the field clean and helps maintain a bloodless plane as we work. One of the most useful tools in this type of case is the Raytech cigar. Its shape makes it ideal for gentle, atraumatic retraction of the great vessels, and it doubles as an effective way to tamponade any bleeding points along the way. Note the use here of gentle sweeping maneuvers using the back of the monopolar scissors. This allows for further creation of the retroperitoneal flap in an avascular plane. We've intentionally left this portion of the video unedited so you can appreciate the meticulous and deliberate dissection required to develop a good flap here. Getting this step right is essential, as it sets up our exposure for the remainder of the case. Throughout this dissection, you'll notice we're continually adjusting arms 1 and 4. This helps generate optimal countertraction and helps the tissue planes open as we work. Here, the inferior mesenteric artery comes into view. At this point, we've exchanged to the vessel sealer, which allows us to seal and divide larger vessels safely in a single step. It uses bipolar energy with minimal thermal spread to surrounding tissue. Continuing our dissection around the vena cava circumferentially, we're clearing a caudal segment here to set up the renal vein transposition and ensure a tension-free anastomosis. With the flap adequately developed, we proceed to tack it to the anterior abdominal wall. The assistant passes a straight Keith needle through the skin and abdominal wall from the outside. Once inside, the needle is grasped and passed through the peritoneal flap and then redirected back out through the abdominal wall, where the assistant secures the suture externally to hold the flap in place. As we continue our dissection in a layer-by-layer fashion, the renal vein starts coming into view here. The same principles from open surgery apply in this robotic approach. We continue dissecting along the anterior surface of the renal vein, working toward the hilum, where ultimately we will identify the superior mesenteric artery. Care is now taken to ensure that the cephalad aspect of the IVC is dissected and freed in order to prepare for vascular clamp placement. Continuing our dissection toward the renal hilum, we now identify the SMA. Small vessels such as this are sealed with a vessel sealer in order to avoid troublesome bleeding during the transposition. Larger tributaries of the renal vein are clipped as necessary. The suction irrigator is used here to clear the field of any blood or debris, allowing us to confirm that the renal vein has been adequately prepared and mobilized for transposition. One useful feature to note is that the suction irrigator doesn't just clear the field, it can also double as a dissecting tool. Gentle, spreading motions with the tip allow for effective blunt dissection. At this point, the patient is systemically heparinized, and the bedside assistant introduces the laparoscopic vascular clamp into the field in preparation for controlling the vena cava. Guidance is provided intracorporally in order to ensure adequate clamp placement. A bulldog clamp is applied across the renal vein here, providing atraumatic temporary occlusion while we prepare for transection and transposition. The venotomy on the vena cava is now closed using a 5-0 Gore-Tex suture. To save time, this portion of the video has been sped up. Once the venotomy on the vena cava has been closed, we remove the clamp and confirm hemostasis. The vascular clamp is then moved caudally in order to transpose the renal vein about 2.5 centimeters below the prior confluence. A venotomy on the wall of the vena cava is created and extended for about 3 centimeters using robotic pot scissors. An end-to-side anastomosis is then created between the properly oriented left renal vein and the vena cava using a double-armed 5 Gore-Tex suture. For a full walkthrough on creating a double-armed Gore-Tex suture, check out our other educational video in our robotic textbook. Once the anastomosis is completed, the bulldog clamp is released in order to ensure excellent antegrade flow from the renal vein into the vena cava. The Scanlon vascular clamp is then also released, heparinization is reversed with protamine, and hemostasis is confirmed. It is our practice to use an adjunctive hemostatic agent over the raw surfaces of the retroperitoneum. The retroperitoneal flap will then be reapproximated using a 3-ovigral suture in a running fashion. Thank you for watching. If you found this helpful, we invite you to view our other educational content.